Well, thanks for this opportunity, Colleen. So it's very difficult to do a talk about this pandemic because something seems to change every day. So the approach I've been taking is actually to give a talk I've been giving for about 10 years now, thus the old-fashioned PowerPoint template you see in front of you, and then try to relate that to what's going on with COVID. So I begin usually with this scenario. There's an attack on Canada. Intelligence services detect the emergence of a terrorist cell overseas. This cell has been developing over several months, but intelligence services missed the emerging threat. Eventually, members of the cell board a plane and come to Toronto, Canada. Canadian intelligence services also failed to identify the threat. By the time the perpetrators are identified and strategies are in place to abort the attack, it's too late. 44 Canadians are dead and 207 are injured. And in response, Canadian and international officials make sweeping changes to surveillance efforts and laws governing the future response to such threats to security. So at this point, I usually ask the audience, do you know what I'm talking about? And then there's usually some keener in the audience who realizes that I'm actually talking about SARS. And the cell is actually, the terrorist cell is actually a virus cell. And the reason I begin with this analogy is really after SARS that people started to view public health threats more through a security lens. And this analogy really makes it evident the connection between public health and other types of security threats we face. So what happened during SARS? And I think it's really important to think about what happened during SARS because that was effectively a dry run of what we are now going through. So in November 2002, the Global Public Health Intelligence Network identified an outbreak in mainland China. So this is a surveillance system actually developed by Canada that before even Netscape existed, figured out how to scrape the web for evidence of disease. And unfortunately didn't have translational capacity at that time, so it was missed. And then in February 2003, the WHO actually reported on the unusual respiratory outbreak. In March 2003, SARS came to Toronto, and it was evident that we weren't prepared. Our surveillance systems were inadequate, and our communication systems were inadequate. So I was actually a physician at Toronto General at the time. I was on call that day, and I got a call from my residents that their mother had watched CNN and heard about this outbreak and had called them worried, and then they called me, and it was concerning to me that that was our outbreak alert system, despite the fact that Canada had developed the GFIN for the WHO. We were relying on family members of our residents to find out about the disease in our local setting. So on April 23rd, the WHO advised international travelers against all non-essential travel to Toronto. And this was important because they really didn't have the authority to do that. And there were significant consequences of that. There was a $1 billion economic impact on Toronto between that announcement and the SARS outbreak. And it had a significant health toll, 44 dead Canadians and 207 fell ill. And I'd like to throw this slide up that just to illustrate how short our memories are. So the time has come to close the book on infectious diseases. We basically wiped out infection in the United States, and that was said in 1967. I think to a certain extent, we forgot about pandemics even leading into COVID. And after any of these events, there's a lot of thought, there's a lot of activity, but it seems to fade from memory and it leaves us unprepared. So to begin sort of discussing how we deal with pandemics and public health threats, I think it's really important to discuss sort of the basic scientific principles behind how outbreaks occur. So what determines if an infection becomes a spreading outbreak? And it's essentially sustained human-to-human transmission. And you hear about this a lot. The WHO hears about something emerging in an area, whether it's MERS-CoV or with H5N2 for a while in Thailand. And then they're always monitoring to see, do we get sustained human-to-human transmission? And when you do, then you're at risk of a spreading outbreak. And what basically determines if it becomes a spreading outbreak is something called the basic reproductive number, or R0. And this is a really simple concept, but it's really critical to understanding how these outbreaks occur. So that's the number of subsequent individuals infected by an infected individual. So if the R0 is 2, for every individual who has the disease, 2 other people will get the disease. And so basically, if the R naught is greater than 1, you have a spreading infection, and if it's less than 1, the outbreak will burn out. And so this is typically our epidemic curve. We see exponential growth, and as we have the disease spread in the community and we start to reduce the effective R naught because you start to develop a level of herd immunity in the population. And then eventually at the top of that curve, the effective R naught hits 1 and then it reduces below 1, and then you have a declining epidemic. So our general goal in tackling outbreaks is to try to reduce that effective R naught to less than 1. And so what are some strategies we can employ to make that happen? Well, as we have heard and learned from COVID, one of the most important things we can do is early detection and introduce mechanisms to try to control the outbreak at source. So this requires having surveillance capacity in place to be able to identify something unusual happening within your borders, and then ensuring that reporting structures are in place so that that gets communicated to the right people, both at the domestic, regional, national, and international levels. And then eventually you have to identify what is it you're dealing with. And this often involves lab capacity to identify the pathogen. And then after early detection, the next step is to try to control it at the ground level. And we've been hearing a lot about social distancing. This seemed like an antiquated term when I was giving these talks in the past, effectively things like social isolation and quarantine, but unfortunately, it appears that it's not that antiquated a term, and it's what we are all experiencing right now. And then antivirals can be used. So in the case, a lot of this planning has really focused on pandemic influenza, and that's sort of governed Canada's response to what we're experiencing now. And the antivirals they were thinking of that time were Tamiflu, the neuraminidase inhibitors. People are now viewing are things like Kaletra, the antiretroviral therapy, or hydrochloroquine, which is the antimalarial therapy. Will they have a similar antiviral effect? Those given to the population, either in treatment or perhaps even in post-exposure prophylaxis, can help reduce your R naught. And then ultimately, our goal is to develop a vaccine. And you've seen this curve several times now, this whole idea of flattening the curve. And the general idea is the earlier we intervene, the earlier we start introducing these measures, the quicker we reduce that effective R naught, and you spread that curve out and you reduce the impact of the disease. So as I mentioned, a lot of this thinking has been governed by pandemic influenza. So after SARS, it was apparent Canada, the world wasn't really ready for a pandemic. And a lot of thinking went into preparing for pandemic influenza. And the reason was we were at that time overdue for another pandemic. So here are some characteristics of previous pandemics. So we were talking about that R naught number. So that R naught number for measles is about 12 to 18. It's probably one of our most infectious agents. For most flu, it's about 1.4 to 1.8. So you're seeing here for Spanish flu is 1.5 to 1.8. We think with COVID it's around 2 to 2.5. So COVID is a more infectious agent, it appears, than our previous pandemic flu strains, which means it affects more of the population. So even if it has a lower case fatality rate, it can affect and kill potentially more people. And here you're seeing the estimated case fatality rates for the various flu pandemics. And we see with Spanish flu, it was quite high, 2 to 3%, and much lower with the other ones. And we think we're around 1% with COVID, though we really don't know how many people have had COVID and how many may be asymptomatic. A recent study suggested in China, it may be actually 4/5 of the population had asymptomatic infection. And then you're seeing what the estimated attributable excess mortality is worldwide, and that's just multiplying that case fatality rate by the population by the infectious percent that you expect to get infected. And importantly, on that final column, you're seeing the GDP loss, and that's a very important consideration in any of these mitigation efforts, that these pandemics have both a health and an economic consequence. And of course, we're experiencing that now with COVID. So with pandemic flu, we typically see multiple waves. Usually the first wave is okay, and then the second wave is the big wave. We're wondering if the same thing is going to happen with COVID, if we're going to have a seasonal sort of reduction in illness over the summer, and perhaps a second wave in the fall and winter. And one of the concepts is that perhaps we can't intervene in the first wave because it takes a while to develop these therapeutic and prophylactic measures, but by the second wave, we're ready. So given this science, we've developed approaches internationally and domestically to combat pandemics, and they're all based on this concept that we have to identify these threats early and intervene early. So after SARS, the world got together and said, what's the best approach to tackle these threats? And the governing document at that time, and still is, the International Health Regulations, but they were out of date at that point. They only applied to diseases like cholera, the plague, yellow fever. And they were revised in 2005 to protect us against any public health threat that can cross borders. So largely infectious diseases, but also possibly pandemic, chemical spills and nuclear spills. So this is the most important document governing the international response to public health emergencies. So the purpose and scope of the IHR are to prevent, protect against, control, and provide a public health response to the international spread of disease in ways that are commensurate with and restricted to public health risks, and which avoid unnecessary interference with international traffic and trade. So this is an important concept. This is not just a document that governs health, but it also governs our economic response. So this emerged out of the International Sanitary Convention, which were designed for cholera outbreaks in the 1800s in Europe. Because what would happen in the cholera outbreaks was that as soon as one country heard about an outbreak, all other countries would start shutting their borders, and this basically stopped the economy in Europe. So they basically got together and said, we're going to let a central agency, a WHO, be an arbiter of when borders could be closed. And the WHO is supposed to make that decision, and countries are expected to follow that decision. And we'll find out with COVID, that's not exactly what happened. So the international health regulations gave the WHO substantial powers, the ability to conduct independent surveillance within a country, the ability to issue unilateral travel recommendations, and it also required countries to develop surveillance systems, report public health emergencies within 24 hours, and develop response strategies. So with respect to international agreements, this is one of the most perhaps invasive with respect to national sovereignty. But at the time, everybody recognized the value of working together, because threats that are not managed within one country clearly has spillover effects that affected the globe. So this is how it's supposed to work. A disease is located at the local level, and then it's reported up through the national IHR focal point. So in Canada, that's the Public Health Agency of Canada. And that goes to an IHR contact point at the WHO. So then the Director General makes a decision. Is this threat a potential public health emergency of international concern? And the Director General gets guidance from an emergency committee that they put together. So for MERS-CoV, this committee had been deciding, but it never reached that level. But for COVID, it did. But some would argue that they took too long to make that declaration. And then the Director General, when that declaration is made, has the authority to issue the temporary recommendations, such as recommending against travel to an affected region. So that's the international approach. And again, it's really based on the idea of surveillance, reporting, and early intervention. And Canada's approach to pandemics, which is again largely influenced by a pandemic influenza plan, is centered upon those same concepts. So our approach was, how do we mitigate the impact of, and again, it was always generally framed around a flu pandemic. And the ultimate solution would be a vaccine. But in the interim, we could use other measures, such as antivirals, like Tamiflu, and non-pharmacological interventions like hand hygiene, social distancing, cancellation of public gatherings. So all of these, as mentioned, reduce the effective R naught, and the general idea is to buy time until you can get a vaccine. And that's one of the fundamental differences between what we're dealing with COVID and pandemic flu. With pandemic flu, we're pretty confident we will eventually be able to develop a vaccine. That is far from certain with COVID. We're sort of starting from scratch. We've had trouble, scientists have had trouble in the past developing vaccines for similar types of viruses. So really we're in the approach of flattening the curve to protect our health system so it can manage the threat, and also hopefully buy time for therapeutic interventions to come forward and then maybe a vaccine. And this is the curve that, again, within the pandemic influenza plan, and is the curve you've been seeing all over the news about flattening it. And the idea is to delay the outbreak's peak, decompress peak burden in hospitals, and diminish overall cases and health impacts, and ultimately allow a definitive intervention like a vaccine to come in. So obviously we're all in social isolation here, and quarantine has been a discussion, and that's been in the news a lot. So when does that work and when does it not work? The basic, again, this goes back to the properties of the disease you're dealing with. So there generally needs to be a long enough time from exposure to infectiousness. And we have to have a low enough fraction of the infection transmitted before the onset of symptoms or with asymptomatic infection, and ideally a low enough reproductive number. So this next image will show that. So this is from the Proceedings of the National Academy of Science, and it shows the proportion of infections that occur prior to symptoms by an asymptomatic infection or by an asymptomatic infection. And one of the reasons social distancing and quarantine worked so well for SARS was you generally weren't infectious until you developed the condition, the symptoms. So you could be isolated easily, and generally the infections actually got worse towards the end of the illness. So social distancing and quarantine actually worked in SARS, and we were essentially effectively able to eliminate SARS through those measures and without a vaccine, which is an unusual situation. On the far right side, you see HIV, and that had a long latency period, so obviously that is a real challenge. COVID actually is the challenge because we're seeing that there's a high percentage of asymptomatic individuals. And so identifying cases and isolating them is really important, though they may be individuals with higher viral load. But the reason we're all socially isolated now is any one of us could be infected, and we have to separate all of us because of the assumption that each of us could have this infection. So the documents governing how the federal government can respond are few. The major document would be the Emergencies Act. This replaced the War Measures Act, and it provides the federal government with authority to take action to address a national emergency. So and under this act, an infectious outbreak would be considered a public welfare emergency. One of the areas I used to study at length was federal-provincial relations in public health. While there's potential authority for the federal government to act in many of these instances, the reality, the current approach is to take a collaborative strategy and to work with the provinces and to not exert any legislative authority on the provinces. So in this case, the federal government has not used the Emergencies Act, and we have seen emergency declared at local levels, at provincial levels. We've seen other countries declare emergencies, and we've seen the WHO declare an emergency, but the federal government in Canada has not declared an emergency. And there's several reasons for that. One is this does have a legacy of coming out of the War Measures Act, and that had controversy associated with the Quebec crisis. And also it is a fairly draconian act that gives the federal government substantial powers, which could be viewed as very invasive on provincial jurisdiction. One of the articles I wrote after SARS was following the CMA's recommendation that we should probably have a graded act that gives increasing powers to the federal government as the threat emerges. So another major limitation of the Emergencies Act is that it requires 2 provinces to be affected before the federal government can act unilaterally. And if we go back to our first principles about controlling an outbreak, that basically means that you have missed your opportunity to control it at the ground level if it's already in multiple provinces. This was a real issue during SARS, where Ontario wasn't working in collaboration with the federal government and wasn't transferring the data to the federal government. So the federal government didn't have the data that they could send to the WHO. The WHO didn't know what was going on, and they brought in the travel advisory, when the reality was, if they had the data, they would have realized that the travel advisory wasn't warranted. So that's sort of a background of where we are now. So just going to briefly talk about how all of this applies to COVID-19. So we know that it was first reported really in December 2019 when Chinese health officials informed the WHO about a cluster of 41 patients with this mysterious pneumonia. It's unclear as to when the WHO actually knew about this or when China knew about this and the reporting. And this has sort of undermined confidence in the entire approach. There's been a lot written that the WHO has been hesitant to bring in recommendations against travel to China. There are several potential reasons. What they have stated in their official documents is that they believe China managed this incredibly well and has been highly collaborative. But there was also the issue that the US had stated their intention to reduce funding to the WHO, and Trump has now stated he was going to hold funding, and China was potentially the source of funding. So that it has been brought up by others. What is concerning, though, is the WHO did take a while to declare a public health emergency of international concern. But under the IHR, the WHO has advised against travel restrictions. So this has been, as you know, disregarded by virtually every country. The US was probably the most prominent initially and was criticized at the time, but most countries have now followed suit. So, and Canada, of course, has closed its borders as well. So this was the fundamental purpose of the IHR. It was to govern this balance between managing a public health threat and impact on travel and trade. And we still have the WHO stating that travel is okay, and we have every country stating that that is not okay. So either the WHO has made recommendations that have been deleterious to the management of this threat, or every country has taken action that have had an unnecessary impact on the global economy. And I think when we look back on this, that's going to be one of the most critical issues. Would early intervention in China, closing of the borders, have prevented this from happening or significantly reduced the global health impact? If so, what's the WHO's role in that? Why did that not happen? Or is it true that the science was such that all of these travel and trade restrictions that we brought in are unnecessary? So I've touched on these points. Why did the IHR not work? So China's compliance with reporting is unclear. The WHO has endorsed China's response. Others have been more critical of it. There's the general issue of the WHO's willingness to bring in measures that would adversely affect a powerful country. The WHO in general has been, even during the Ebola outbreak of 2014, very hesitant to bring measures in. And again, going back to first principles of disease outbreaks, it's better to act quickly early on than wait and make sure. This is a fundamental principle in public health in general. Just like Canada Emergencies Act, the WHO's approach of waiting for it to be declared a public health emergency of international concern before it has the opportunity to issue these recommendations misses that window when early action can be beneficial. We also live in a different world. The IHR emerged in a time when global collaboration was really looked upon as a solution to many of our problems. And now we live in a world more defined by populism, where countries are acting increasingly in their own interest. And even if the WHO issues recommendations, it's unclear whether many of these populist countries, and now increasingly most countries, are going to follow those recommendations. So just going to conclude. So where are we going to go next? So as we know, unfortunately, much of the world is in lockdown, and this has had an enormous impact on the global economy. Some estimates of 20 to 30 trillion. It's going to be a huge consequences both economically, socially, and we're struggling with this balance. How do we control this epidemic, but how do we not have these other impacts? Is the curve flattening? I think we're starting to see, perhaps in China, that has happened. They seem to have starting to reopen Wuhan. In Italy and Spain, it looks like that might be happening. And it does look like the social distancing measures have had an impact so far in North America, that the epidemic is not what it might have otherwise been. But then the big question is, if so, then what? So the general idea with COVID is that 50 to 70% of us need to be infected before we achieve herd immunity. And if you're highly successful in preventing the spread of disease, then less of us will get exposed. So that means you have to maintain these measures even longer. And again, going back to pandemic flu, that sort of works because you will eventually get a pandemic flu vaccine. The problem with COVID is we're not guaranteed we're going to get that vaccine. So if a small percentage of the population is only exposed, as soon as we let up these measures, that's a highly vulnerable population, those that haven't had the disease, and it can just flare up again. So hopefully, because of the potential for either micro-infections or asymptomatic cases, a larger percentage of the population is actually infected than we actually know. I understand that there may be 500 clinical trials going on right now in COVID, so maybe we will have some therapeutic interventions that could be also used prophylactically that can help reduce this effective or not. But if that's not the case, we have to figure out a safe way to expose the population. And that might be in waves where we reduce the measures for a while, hopefully have a controlled exposure. Then as soon as evidence that the rates are starting to go up, we shut things down. And that's sort of what you've been hearing in the news now about this intermittent strategy of opening and closing restrictions. Something we've been working on and has now really started to capture the attention globally is the idea of immunity certificates. So we know potentially that maybe, hopefully, optimistically, 20 to 30% of the population may have already been infected. And if so, they may have evidence of immunity in their bloodstream, and that could be detected with a serological test that looks for antibodies. The general view is if you have these antibodies, it means that you've been infected and that you are probably immune to this virus for at least 2 to 3 years, because the virus does not really mutate that much. And if so, can these individuals re-enter, leave social isolation and try to get back into the workforce? This will be most important, obviously, for frontline workers, healthcare workers, but it'll be increasingly important for society at large as we try to get back to normal. And so this is Germany is looking at this, the UK has announced an immunity passport, and the idea is to digitize these certificates, have a standard where countries can accept each other's credentials, because like the yellow fever vaccine, this will likely be required for international travel, at least in the initial stages. And but obviously this concept, there's a lot of controversy with it as well, because it essentially penalizes those that took measures to protect themselves and protect others because they may not have been exposed, and then they have to suffer the consequences of that by not being able to leave social isolation. We are waiting for a vaccine. Hopefully one will become available. The sense is if they are able to develop an effective vaccine, it will confer immunity that's relatively long lasting because the virus does not mutate. And then there's the issue of seasonality and multiple waves. And we're optimistically, I think there's a hope that this subsides somewhat during the summer. We know cold viruses don't spread as well in the summer, and that can be because of a combination of UV light and humidity. But again, there's a lot of uncertainty about that as well. So that's a general overview of sort of where we're at, where I kind of expect things to go. I'd like to ask people to follow us on Twitter at CANImmunize. If you want to find out more about CANImmunize, that's the website. And we made a comic book, immunitywarriors.com, that sort of explains how viruses work and infect cells. That would be for those wanting to get a primer or show their their kids, that could be a way to educate them.
That's great, Kumanan. Thank you very much. Can you hear me okay, Kumanan?
I can.
Okay, great. So we've got a bunch of questions here. So I'll try and round up a few of them, and if you're able to respond. I might start with this one about herd immunity and a concern that herd immunity is, you know, a form of kind of survival of the fittest. And also an earlier question that relates to this is the concern about a lack of focus on testing and contact tracing across different provinces. So as between the two of these things, what is the right balance, and should we not have much more effort on testing and tracing? Or is it a problem that we have so much possible widespread infection that the contact tracing idea goes out the window?
You know, I think it's a fundamental concept of disease control is to identify cases and remove them from circulation. It's best done early, but it's effective at any point in the process. The challenge, of course, with COVID is if up to 80% of us are asymptomatic and infectious as an asymptomatic individual, you know, that spread will still occur. I'm not certain of this fact, but my sense is that those with symptoms are likely those with higher viral loads and are probably more infectious. So it's still a very important strategy. It's going to be particularly important in those frontline workers who are coming into contact with vulnerable populations. So, you know, that was what the WHO says: test, 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 identify, isolate. Hopefully, we can control it that way. With respect to herd immunity, you know, that is the ultimate goal of any of these strategies. And it's generally it's 1 divided by the R naught is what you need. So if it's 2, it'd be about 50% needs to get 50% infectious rate would sort of give you herd immunity. Herd immunity is a difficult concept. It sort of suggests that everybody is evenly distributed in the population. And that may not be the case, and it particularly wouldn't be the case here. I suspect most of our infections are going to occur in the youth. And so that may look like a lot of people have gotten an infection, but in our elderly, in our seniors, they may not have herd immunity, so they're still vulnerable. So conceptually, it makes sense that we hit a certain threshold and we're okay, but it isn't necessarily the case. One of the potential opportunities with COVID is that we could, you know, if the infections do occur and are less vulnerable, and we reach a certain threshold, it can avoid having to get a more vulnerable infected to protect them.
Can you just explain that again? What do you mean by that? So if there's enough.
So let's say we get 65%, let's say we need to get 65% of the population infected or immune in order to prevent the spread. That doesn't need to, you know, if we know that getting people over 70 infected is high risk, can we sort of have a situation where the less vulnerable are exposed and infected to get that herd immunity? UK and Sweden tried that strategy, and it doesn't look like it's worked out because you just can't control the spread that well. And a lot of those healthy do come in contact with the more vulnerable, and they had to backtrack. Right. So they're back to the social isolation strategy.
Okay. Kumanan, every time you move the computer, it makes this gigantic rustling sound. If you could keep still, that would be super awesome. So what is your view about the levels of contact testing and contact tracing that is happening across the provinces? One of the questions is a concern that we are not doing enough in any particular province, even in the provinces with the highest number of testing and tracing going on compared to other jurisdictions. So the World Health Organization has said, you know, test, 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 and isolate. What's your view about at what level should each province be at, perhaps?
I think this general sense that the BC has probably done this the best. Their strategies they've been able to test a higher percentage of their population, and as such, it looks like they flattened their curve. I think this is an unprecedented situation where the amount of resources, lab materials was not expected. I think that's an omission virtually every country has made in their preparedness. We, again, to go back to an original point, we sort of forgot these things could happen and didn't really have mechanisms in place to do interventions at this scale. At this point, I mean, for this to be effective, it needs to be done early. It still has value now. We are developing the testing capacity, but as the gaps in testing have contributed to more spread and community spread. So yes, it appears to have been not the sufficient capacity in some areas to shut this down. And we need to sort of, that's being shored up, but it is contributing to the disease taking in different characteristics in jurisdictions where they couldn't test at the same level as in others.
Okay. One question I just want to go back to was around the issue of the World Health Organization's initial position on travel ban and the criticism that it has received. And then in turn, Canada holding the line on that for some time while other countries were putting in place travel bans, but then eventually it too has put in place a travel ban. So do you think you kind of left it open-ended, you know, in the post-mortem of COVID-19, we'll understand who was right, the World Health Organization or kind of the rest of the world. Do you have more of a view on this? Does COVID-19 experience of COVID-19, do you think we are going to be changing, the World Health Organization will change its position about travel bans, given that arguably if we'd shut this down much earlier on, then the vectors of the disease would have been much more easier to isolate and contact trace within Canada than it currently is?
Yeah, so I mean, I'll be honest, I think the international health regulations failed in COVID. This is not how it was supposed to play out, and it's had disastrous consequences. I think they're going to have to be entirely revised, if not just not or thrown out altogether. This didn't work. The WHO has stated that because there's community spread within countries, there's no real point in closing borders because you're already getting spread within your borders. Countries can exceed a WHO recommendation, but they have to provide public health justification. WHO has sort of sent some mixed messages because they've said that countries that did a good job early on in managing this shut their borders to China, but they still went ahead and said that there's no justification for shutting their borders. So I think this really does undermine the IHR as a document governing these threats, and we're going to have to figure out another way to do this. And I'm not sure what that's going to be, but we are in a different world than the world in which the IHR revisions took place. We might start seeing more region-to-region arrangements, the EU working with North America and such. And that's sort of what we're hearing with Trudeau talking to the G7, coordinating their closing of borders to the G7. It seems to be bypassing the WHO. The WHO also is not recommending masks in public, and we're seeing that countries are again going against that recommendation as well.
Okay. One question that's come in is, you mentioned the hopeful prospect about that many of us would acquire some form of immunity from contact. And one person has asked here about the study reporting low antibody levels in recovered patients and no sign of neutralizing proteins, referring to a particular research. Do you have concerns about this, that we may not have that kind of immunity that we hope for, expect post if this was a flu pandemic?
Yeah, so I think that's an important scientific question that still has to be answered. What level of immunity do you have? How long is it going to last? and what level of antibody titer demonstrate that immunity. So the FDA just, I think, approved the first serological test a couple of weeks ago. So these are just all hitting the market now. We don't know what their sensitivity and specificity is. It's going to be really important to have a high quality test, and then we're going to have to determine if that does confer the immunity you do need. My understanding from the scientists is that they believe that if you have a natural exposure, you will develop immunity, and it should last for 2 to 3 years. But as we're learning with COVID, there's a lot of uncertainty in the science, and there's a lot about this virus that we don't know, and is very unexpected. So it is plausible that, again, these are questions that are going to have to be examined.
So if the worst case scenario comes to pass, that there isn't this kind of herd immunity, or not at least in the same kind of way that comes about from exposure, what's the game plan then? Like what can we expect?
So I mean, and I think part of my concern is it feels like there isn't a game plan, but the hope is that of all of the scientific activity, something will work. This is an entirely different condition. If it's treatable, then we might be okay with letting people get infected. They may get sick, but as long as we can treat it, like a bacterial pneummonia, maybe one of these interventions that's being examined now, the convalescent plasma or hydrochloroquine, is effective in that way. Or perhaps we develop interventions that are useful in prophylaxis, that to reduce the spread and, again, reduce the effective or not. Maybe there'll be seasonal effects that reduce the spread of the virus. But ultimately, there are only two, from what I understand, there are only 2 vaccines in phase 1. One is sort of an artificial immune stimulant, which that company never had anything go to market, and the other one's out in China. So we're really starting at ground zero on the vaccine development. It will be accelerated. The vaccine will likely get released a little sooner than it normally would be. But just to be cautionary on that point, in 1976, there was a concern about a pandemic swine flu, and they released a vaccine early, and it had an 8 to 9-fold increased risk of Guillain-Barré syndrome, which is a rare paralytic disorder. And then the swine flu never occurred. So we just have to be careful with all of this. It's important to do the scientific evaluation, the studies, but we do also feel the pressure to get a solution out soon.
Okay, so basically, if we don't have this herd immunity, then the vaccine, not all our hopes, but our hopes are pinned on the vaccine.
Or a therapeutic intervention. If this becomes a treatable condition, I think it's going to be looked at differently.
Okay, so if we just pause to think about that, a treatable condition, can you just discuss at the moment what are the means that are being used to treat COVID-19 once it has been identified, the symptoms? What are we currently using, and what is on the horizon? Where should we be putting our efforts here? And one person has asked about particular ventilators, BCG. I'm not sure what those are. There are interpretation that BCG's vaccinated countries have less. Oh, sorry, the BCG vaccine.
So right now we're all sort of. So when we look at our hierarchy of evidence, our highest level of evidence is the randomized control trial. We don't have any randomized control trial data on any of this, so we have to use lower levels of evidence, including case series. So that infamous interaction between Dr. Fauci and President Trump, where President Trump had a good feeling about hydrochloroquine, and Dr. Fauci said it was anecdotal. Well, at this point, a lot of us are acting on anecdotal evidence because that's all that's available. It's unclear early on what will work, but what being tried are antivirals, so like Kaletra, which is an HIV combination, and Rabinavir, or hydrochloroquine, which is an anti-malarial, and azithromycin. We should be seeing a flood of study results coming out soon on those. I'm guessing they aren't going to be game changers, but they might reduce your risk by 20% or so, but that's just speculation on my part. And then there are several other therapies being looked at. There's immunosuppression. It's apparent that in some individuals, why they're dying is not because of the overwhelming infection, but what they call cytokine storm, which is just the immune system overreacting. And so they're looking at immune suppression modalities to try to control that. Something people are hoping for is convalescent plasma. So that's taking blood from individuals who have had the infection, and they should have produced the antibodies that can be useful, and then putting that into individuals who are severely ill. That was apparently tried in China. Case series suggests that that may work. One of the issues that I find a little unsettling about all of this is we're really using 1800s medicine. Like, we're using quarantine, social isolation, contact tracing, and that's all been the best, most effective thing we can do. We're looking at an old antimalarial, even convalescent plasma, something that came out of the Spanish flu. I think we really do need the scientists to come forward with something novel, or else it continues to be a real challenge. The BCG vaccination is an interesting one. Again, all needs to be scientifically studied, but there's a perception that maybe there's less of the disease in India than there is in other parts of the world. So I was speaking to an epidemiologist and said some of this has been because of the fact that a lot of these lower income countries have a much younger population, where a high percentage of the population are in the low risk group, and so you just aren't seeing it. While in Europe, where the population is much older, you're starting to see it. So they may have the same attack rates, but it's much more apparent in a country where the population is older versus younger.
Okay, that's really helpful. And one question that came in was the apropos of how we respond and how we treat is the results that we see in Hong Kong, which according to a question here or comment here, Hong Kong has about 4 deaths as of this week, and they seem to have about a 27% recovery rate. Is that due to the underlying, that the individuals weren't as sick as what we are seeing in other places, or do they simply have better means to treat those people there?
There are obviously going to be multiple factors, but I think some of the things that need to be looked at is what are their age distribution and what are the comorbidities. I think one of the problems in Italy was older population, a high smoking rate in that population, and a lot of individuals with cardiovascular disease. The other major factor that seems to influence the overall mortality rate is the healthcare system capacity. In Italy, they were overwhelmed quickly, and ventilators filled up, and so temporary mechanical ventilation, which could have helped some of the lower illness individuals, wasn't available. So in a country where you can maintain access to that rescue therapy, you're going to reduce your mortality rate. And I think one of the theories for why Italy was so high, they just overwhelmed their health system so fast. That was a warning signal sent around the world, and that we need to build that healthcare capacity and the ventilator capacity.
Okay. So just related to that, Kumanan, what do you think about our capacity here? When I look at the statistics on the number of hospital beds and numbers of physicians and nurses per capita, we're much lower than what we see in Italy, for example. This suggests we could be in deep trouble. What do we need to do to bring on more capacity now which would then allow us more options, perhaps, in terms of reducing the need for physical distancing?
Maybe I'll just make an overall statement for that. I've been, even though I've been a consultant at the WHO, I've been very comfortable saying that their response, the IHR, has not worked well. And in the past, I've been critical of Canada's response to public health threats, SARS, listeria in particular. I would actually say overall this has worked to this point well. Our leaders have worked collaboratively, particularly compared to what they've done in the past. We have had an opportunity to see what's happened elsewhere and prepare. We have delayed or flattened the curve somewhat to buy us time. But what we're starting to see, and this is going to be a global reorganization of the economy, is that because of globalization and requirement and dependencies on other countries, we just didn't have internal capacity to build this. And we're seeing one of the most rapid shifts in industry to provide that capacity. So obviously I'm a healthcare worker and I need to be optimistic, but I'm cautiously optimistic that we may have been able to delay the peak to a point where we will be able to get that capacity. But we're seeing the problem with international dependencies, with the whole recent controversy about the 3M masks. And even I understand India is threatening not to export its hydrochloroquine. So, there's going to be a rethinking of globalization after this, and the need to develop essential industries within your borders.
Okay. We're getting near the end of the time. I just wanted to ask one question which has come up a couple of times, which is about the apparently much higher rates of COVID-19 within Quebec. Why is that so relative to other provinces? Is this just the higher rates of testing and so forth? Why are we seeing higher rates, and are there really higher rates there?
Yes. So I can give two theories. One is that it could be testing. So I'm not really a big fan of these test numbers. We know people are being turned away from testing because their symptoms are not sufficient and tests are scarce. We know that the lag in getting test results back. The numbers I follow are hospitalizations, ICU admissions, and deaths. I think that gives us a better sense. There's also, Quebec had their March break earlier. So they were hit by the influx of foreign travel before really having an opportunity to act. Others saw that resulted in BC and Ontario taking the measure to stop travel right prior to March break, because that would have been probably catastrophic if we had 1 million people come back infected or at risk of infection into our borders. So that's a factor. There are also going to be cultural factors. More gregarious societies are going to probably have more spread of, and more concentrated populations are going to have more spread of infection. New York City, that's one of the major issues, and by far the most concentrated population in the US.
Right. So the recording in Quebec, only 130 deaths from the 9,000 cases. If the death rates are being recorded properly, is this a hopeful sign about the number of people that might be infected, broadly within the population?
Yeah. So these deaths are going to, again, you have to be cautious with these death statistics. Several issues come to mind, like how many of these actually died of the disease or with the disease? How many of these deaths would have happened 3 to 6 months later? And are we capturing all of the deaths? So in France, you've just seen a huge spike in reporting of deaths because they weren't capturing the long-term care home deaths, which seemed a little odd to me. So they've gone from like 300 to like 1,200 deaths a day. So hopefully we are capturing all the deaths, but I think there have been problems in doing so. So while I say those are the best numbers to look at, we also have to be cautious there. But to end on a pseudo-optimistic note, some of the Imperial College did a lot of their models at the outset of this that raised the alarm bells, and they have downgraded the outcome numbers, which is good. They have suggested that some of these deaths were in individuals who were near the end of life as it was, and they've also, another competing model out of Oxford has suggested that there may be a reasonable level of immunity in the population. So just maybe to end, I think the most important scientific information that's going to become available in the next months is countries around the world are doing this serosurveillance. They're looking at, like blood systems are looking at antibodies in their blood donors. We're going to get a good sense when these results come back, where we're at. If we're at 5%, might be a little depressed. If it's at 30 to 40%, we're not too far from herd immunity. There may be a light at the end of the tunnel. So that's what we should be keeping our eye on.
Okay, well, that's really helpful advice. Kumanan, I wanted to thank you all. Folks are asking if we're going to share this presentation, and we will. So we're going to make this available online. Kumanan, I want to thank everyone, thank you on behalf of everybody online. All the notes are coming in saying thank you very much for the great presentation. And also thank you for everything that you're doing in response to COVID-19, both as a clinician, which we know is no easy job these days, far from it, as well as your work with all of the innovations that you're working on to try to get out ahead of this. So we really appreciate it, and we might ask you to come back for another webinar in a couple of weeks if you're game, so we can update everybody on progress, hopefully progress, right?
Yeah, hopefully we'll can do it in person next time.
Yeah, well, that would be nice, but I don't think so in a couple of weeks, so you're not getting out of it that easily. My friends, thank you very much for joining us. We really appreciate it. We'll probably be hosting other webinars in the coming weeks, so we'll let you know. And thank you very much, everybody.